Good afternoon. This webinar is part of the California Institute for Behavioral Health Solutions KDA webinar series. This project is funded through a contract with the Department of Healthcare Services. Additional technical assistance and support was provided by Lisa Molinar and Rich Weisgall of Shared Vision Consultants. Today's webinar is Implementing KDA through Collaborative Decision Making, Small County Perspectives, Part 2. It continues the presentation and discussion on small county implementation of KDA Pathways to Wellbeing begun on the June 24th webinar. We also want to let you know in terms of our overall goal here is that successful KDA implementation requires counties to collaborate across the child welfare and behavioral health agencies. That means that frequent meetings to decide about protocols and procedures, roles and responsibilities, resources and services. This two-part webinar mini-series will take you inside the workings of several small counties as they move forward with KDA implementation stories. You'll hear their stories, lessons learned, and we hope that really helps inform the work of all counties, regardless of size. So before we get going here, we're going to have 3 polling questions, which should come up in just a moment. And our first question is, please tell us where you work. Are you state or county child welfare, state or county behavioral or mental health, contract agency or a CBO providing services, education or training organization, or others? So go ahead and vote. And we'll have the response here in just a moment. Okay, we're going to close the poll. So we have 31% are state or county child welfare, 44% are state or county behavioral mental health, 6% are contract agency or CBO providing services, 13% are an education and training organization, and 6% are other. Great, thank you. Okay, we're going to go to our next polling question. Please let us know the nature of your work. Do you work directly with children and families? Are you a supervisor or a manager? Are you a family partner or a youth or peer provider? Are you a consultant or trainer or a technical assistance provider or other? Okay, we're going to close the poll. And 26% of you work directly with children and families. 39% of you are a supervisor or manager. We have no family partners or youth peer providers. We have 90% are consultants, trainers, or TA providers, and 16% of you said that you are other. All right, and we have one final polling question, and then we'll move on. So our final question is, how would you rate your county's cross-agency collaboration with regard to KDA implementation? Strong, average, or we're still developing our collaboration? Okay, we'll close the poll. And so 28% say their collaboration is strong, 48% of you say it's average, and 24% are still developing your collaboration. Great, thank you very much for that. Okay, so we're going to go on now with the rest of our presentation. So we're going to start with Mariposa County. We're welcoming both Mariposa and Madera counties, and they'll be discussing how their child welfare and mental health agencies work together to develop and implement their KDA programs over the past several years. We'll begin with our Mariposa County presenters discussing their program, which will include some of the highlights and challenges of their cross-agency partnership. Madera County will then present highlights from their accomplishments and challenges regarding both program implementation and collaboration. Finally, we will open it up to questions from the webinar participants for all the presenters to answer. So we're going to begin with Mariposa County, and I'm delighted to introduce our two Mariposa presenters. Susan Arlington has been a supervisor in child welfare services for about 13 years, 10 years in Mariposa County and almost 3 years in Merced County. She previously spent 7 years in Florida working in custody evaluations for Broward County Family Court Services. She has a BA from UCLA in psychology and a master's degree in educational psychology from Cal State Northridge. She is also a licensed marriage and family therapist. Susan has been the child welfare lead for KDA in Mariposa County since implementation of the settlement agreement. And we also have Chrissy Doss. Chrissy began her work with both the child welfare services and behavioral health systems 13 years ago as a foster parent of a teen mother. That experience introduced her to the social work field. She returned to school and graduated with her MSW from CSU Bakersfield in 2009, and she received her LCSW in 2014. She has worked for nonprofit community-based organizations and child welfare services serving foster youth since 2007. In 2015, she started her new role in behavioral health as a mental health clinician, and she is now the supervisor for the Children's System of Care in Mariposa County. So with that, I'm going to turn this over to Mariposa County.
Thank you. We are happy to participate in this webinar. And I think the first slide will address the strength of collaboration in a small county such as ours. We are the 6th smallest county in the state and have a total population, including Yosemite Park, of about 18,000. So we really do have a small county perspective. And one of the strengths of our collaboration between Chrissy and me, is that we both have child welfare services and mental health backgrounds. We're both licensed clinical supervisors, and we have experience working in both systems. We also are both familiar with safety organized practice and the implementation in child welfare services for safety organized practice, and how that is analogous to things such as RAT meetings, TDM meetings, action plans, and corporate practice model, and all manner of KDA practices. So we have a very strong collaboration. We've known each other for many years, and that brings an ease with each other in terms of our collaboration. Because we are a small agency and we are all in one building and under the umbrella of Department of Human Services, our agency is both social services encompassing child welfare and behavioral health and recovery services for mental health and AOD. And so we're all in the same building now, which we were not 5+ years ago. So by virtue of the fact that we are co-located, we have access to each other. We can just march upstairs or downstairs and sit down and talk, and that eases the collaboration quite a bit.
Yeah, so though we have that as a strength, it makes it much easier to work together. Being in such a small county, we definitely have some challenges. So on the next slide, you'll see that we don't have any community-based organizations that provide any mental health services to our clients. So everything we do, whether it's, and this is KDA, but KDA RAP, full service partnership, is all in-house. So it's all county staff from the behavioral health system. So So with having limited resources, it makes it really difficult sometimes to be able to meet all the needs of our clients. And one of our challenges with being a small county, just like Napa, I think they kind of talked about this last week, is we have a high staff turnover. And so then that means that as new staff are coming in and old staff are going out, it begins the KDA training all over every time. And some of our staff who come in, they're not trauma-informed. They're not familiar with trauma-informed practices like safety organized practice and KDA. And so there's a whole time frame of getting them on board and restarting with our families and things like that. We don't serve a large population here, so that's kind of a good in that sense. But like right now, I think we're serving approximately 4 KDA families. So just to kind of give you context of small county Mariposa KDA. So the next slide.
As Chrissy just mentioned, but in both child welfare and in mental health, we are totally invested in trauma-informed practice. We have, some time ago, I was very intent on making sure that my staff was received trauma-informed training, and Chrissy now in behavioral health has absolutely been proactive in getting her clinical staff exposed to and trained in trauma-informed practice. Now, because of the requirement for child welfare to utilize a screening tool for referrals to mental health for KDA class, KDA subclass, traditional mental health, children's assisted with care, possibly REP, any of the above services, mental health services, I researched long and hard a number of tools to utilize, to select, to have my staff, my social workers use as a screening tool to accompany referrals to mental health services. Finally settled on the UCLA PTSD Reaction Index. Number one, because of the trauma-informed tool. Number two, because of the ease of administration, and it is hand-scored. We had to purchase it from UCLA, and also it is user-friendly. I wanted a tool that social workers would actually use, and they're finding it, we haven't used it too much thus far because we have so few referrals, and thus, as Chrissy mentioned, not that many KDA cases at present. But it is important for a tool to be easily administered, user-friendly, and trauma-informed, and useful for the mental health staff. And not only had Chrissy previously been exposed to this tool, now she is absolutely getting her staff on board with the same tool.
Yeah, it's using the UCLA PTSD index. It's a nice seam line between the referral. So what happens is child welfare services, they attach it to the referral and send it over to behavioral health. And then what it does is it really gives the clinician a snapshot of why this referral is being made and what areas there are trauma, and for the clients, what they indicate as their greatest trauma. So then it helps to focus in the work that's going to be done with the family, so that it's not just our assessment through, we use Anasazi, so we're not just using that assessment, but we're also using this tool And we're actually, it's not on this slide, but we're in the process of having our clinicians trained in CANS so that we can also use that for like the child-family team meetings and to get real clear about what direction we're going with these families and the hopes and goals when they're done with us, once they go through both of our systems, both child welfare and behavioral health. So currently we have one clinician who is in training. It's a one-year training for trauma-focused CBT, and the UCLA PTSD Index just is part of that training as well. So that was a good use of that. And then we have another clinician who is training. She's trained in seeking safety, which is also a trauma-informed modality. So so that's kind of where we're at in Mariposa County. And I think on the next slides, we just kind of go into the tools and training, just kind of recapping what Susan and I have talked about.
Yes, well, as I previously mentioned, we did purchase the tool. In fact, we couldn't download it until we actually had purchased it, but it was very reasonable and it'll last us a good long time with our small numbers. And we are in the process of utilizing it. As Chrissy mentioned, we utilize the tool and attach the scoring sheet to the referrals to mental health. And then we can always, supplement any information that the clinician may need as the treatment plan is developed.
Yeah, and like it says on the slide, the trauma-focused CBT training that we've connected our staff with is free. There's a one-week initial training, and then there's monthly phone conferences, and then there is a specific certification at the end of the year. You have to attend all 12 months to get the certificate. But I think the clinicians are finding it really helpful in being real direct with the work that they're doing with these clients. So on the next slide, you'll see the Seeking Safety training, and it's a 1 to 3 day training depending on where you go. If they offer it throughout the state, and the cost is really minimal. And then you'll see the link to that if you're interested.
And now I think we will take a look at, for anyone who's interested, the actual tools, the UCLA PTSD reaction indices for, one is children, adolescents, and then also one for parents and caregivers. So we can probably just scroll through those, give you a sense of what that tool looks like for those who have never seen it. This is for the children and adolescents, and this is completed by pretty much by the social worker, unless the child is of age, probably a late, mid to late adolescent, probably completed itself. But it really is there are some delicate questions here. So I think it's a very good experience for the social worker to actually work with a child or adolescent in completing this, getting the responses. So again, there are any number of traumas addressed here, as you can see. Anything from the abuse and neglect and serious accidents, life-threatening injuries, kidnapping, sexual assault, bereavement, interpersonal violence. So it encompasses a lot, and some of them are absolutely delicate questions, which is why the social worker, by and large, completes it with the child. And then there is a scoring sheet that it is utilized after the responses are achieved with the child. Again, other self-report trauma history. This is another screen of different questions that are worded a little bit differently with yes or no responses. And then subsequent to this, then we will give any impressions or any other statements that can be added that are open-ended, and then we will utilize the scoring sheet to record the number of traumas that are indicated in any number of areas. Again, this scoring sheet, which should be coming up next, if we scroll down, we can probably get to that. Again, these are our other questions. The tool is made up of a different array of questions in different formats. And this one gives you some scores. And this is how we score utilize the scoring sheet. Should be coming up. Yeah. Next slide. So then this is actually the frequency rating sheet, but the scoring sheet is actually the next slide. Would be, yes. So this is the scoring sheet that will give you some sense of where the most trauma for any given child has occurred. So this is, or any notes that we want to make on this, this is what we will attach to our referral form to mental health, and then that can Chrissy or her staff will determine the areas of focus for a treatment plan and eligibility for KDA class or subclass. And again, there we could probably just scroll right through. There is the other tool is for parents and caregivers, which we actually haven't been utilizing thus far. We've pretty much been focusing on the child-adolescent tool. So, but we do have this one available as well, should we need it, or if behavioral health may want to utilize it as they work with families. And we can probably just scroll right through it. It's pretty much the same format, except it's asking for responses from a parent or caregiver as opposed to a child. And of course, this can be completed individually by the adult, of course, which eases sort of probably the streamlining through that. So we haven't utilized that yet in child welfare, but we may be doing that soon, and as may possibly behavioral health. There's also a manual that was provided by the UCLA, the entity from whom we purchased this tool. So the manual is sort of an assistance to social workers in completing the tool, giving sort of a guide through working through the tool. And of course, this is commensurate with DSM-5, which is of course important, the most recent revision to DSM. So certainly it's an up-to-date tool, it's useful, it's user-friendly, and it is both child welfare social workers and mental health clinicians are on board with it, which makes our collaboration even better. And I guess that's pretty much the sum total of our presentation in terms of our strengths, our challenges, the strength of our collaboration, the challenges, but the privileges of working in a very small county, the sixth smallest. And Christy and I have been very happy to present our perspective on KDA. We will be attending the statewide convening on August 6th, and they're going to present at that one too. So we're very grateful for your attention, and we'll turn it over to Madera.
Great. Thank you, Christy and Susan, for a really informative look at Mariposa County's programs. So now let me formally introduce our Madera County presenters. We have several presenters today. We are starting with Patricia Cadillo. Patricia received her BSW from San Diego State in 1995 and her MSW from Cal State Fresno in 1999. And she has over 19 years of experience in child welfare services, the past 3 of them with Madera County, where she serves as program manager with the KDA program. Art Galindo is a licensed clinical social worker with approximately 20 years of experience as a behavioral health professional. For the past 10.5 years, he's worked for Madera County Behavioral Health, first as a caseworker and then as a mental health clinician, and since 2012 as a supervisor. Keith Crawford has been in the mental health field for over 20 years and has worked for Madera County Behavioral Health for the past 11 years. He serves as the caseworker on the linkage and placement team and as the intensive care coordinator for the KDA program. He's also been the interagency placement committee coordinator for the past 10 years. And finally, we have Mi Wang, is a child welfare services supervisor in the permanent placement unit in Madera County. She previously worked as the coordinator for the independent living program and has also been a group home case manager. She came on board with KDA in October 2014. So now I'm going to turn it over to Madera County. And we're experiencing a bit of a delay between in the slides changing. It's not our. It just seems to be the internet interface. So be patient.
Okay, hi. My name is Mi Wang. I will be starting off today's presentation from Madera County. And we're just going to go in this order. I just want to let you guys know that I will start off, then it will be Patricia, and then Keith, and then Art Galindo. All right? So moving along, the objective or the purpose of today's our meeting today is to show the implementation process of KDA in a small county. Madera County is not as small as Mariposa, but we are pretty small. You know, our case our case number range between 200 to 300. So a little bit of history about Madera County is that we have been working on related. We've been doing this for a long time before it was KDA. So in Madera County has, prior to KDA, Madera County has had a specific foster care mental health program since the 1990s. We've had an existing MOU between BHS and DSS, and we've used the MIST tool as the assessment tool to send over referrals for mental health services. And the levels of treatment were determined through the IPC process, which is the inter-county placement process. When KDA came into implementation, what we started to do in January of 2014, if you can go to the next page. In January 2014, we initiated conversations between our department and BHS. We met weekly. I mean, it was every week. I believe it was every Tuesday afternoon, Monday or Tuesday, I believe, every afternoon, where we identified what we needed to do. So in these meetings, what we ended up doing was identifying cases, developing forms, identify roles and responsibilities, and we, after all of that was done, we implemented our PBG and started that training piece for staff in the county. All right, so I'm going to leave it to Patricia to go to the developmental phase.
Good afternoon. Thank you, Mee. I will go over some of the information that Mee just provided, going back into how we started the conversations with behavioral health and child welfare. As Mimi indicated, it seemed for us in Madera County that we were, in comparison to other counties, we were maybe like a step ahead in that we already had an internal process of referring children to behavioral health, and we already had a tool that at this time is also being used throughout other counties as well. In addition, with our process, we also we have a program, Healthy Beginnings, which our Galindo will go more in depth, but that's for children 0 to 5, where we refer automatically over to Healthy Beginnings, and they do an assessment whether the child needs behavioral health, physical, educational needs, and so that's already a process that we had in place that we've continued with our KDA. So moving along with our conversations with behavioral health, they did start in January 2014. Those were weekly meetings, and what really helped us through this process is that we didn't have to start. We didn't start from scratch, meaning we already had some fundamental steps in place, in addition to then going through the different convenings that we created relations with other counties that assisted us through our development process. We've used forms from other counties. One of the counties that I particularly was looking and had been in contact with was Tulare County. And we also borrowed some forms from SLO County and other counties as well. And from there we went. It was as many of you know, some of our obstacles more laid into our communication and how we could better keep track of the children that we refer to behavioral health and identifying the needs and ensuring that those needs were being met. And also, the other is once the child is in care and meets the criteria, how are we going to ensure that, like I said, that they're getting the treatment that they need. And the other part is for those children who initially did not need medical necessity, how are we going to ensure that if there is a time while they're in care that they do need the services, how are we going to ensure that this child is going to be referred to behavioral health? So as you can see in this slide, then what we did, we ran business objects reports and through safe measures and identified the children who were in all the different programs. From there, we, like I said, we identified the children who are 0 to 5 who were screened through the Healthy Beginnings. And then our children 5 and no older are being screened with the MIDS form. The KDA form is just the eligibility criteria that our KDA coordinator, DSS coordinator fills out when sending the referral over to behavioral health. So some of the roles that we developed are, like I said, the KDA coordinator through behavioral health, or KDA coordinator through DSS, or support staff, and then our ICT coordinator and our facilitator for the CFTs. When we identified the children, and from that point on forward, ensuring that we were tracking every time that we did a MIS referral and a MIS completed and a KDA referral, and that we kept track of them, and also getting the feedback from behavioral health and indicating whether they met the criteria or not. And that part was very, in that process, our conversation was, okay, so then if the child does not meet medical necessity, and the child does not have any behaviors later on that indicate that they need a referral to behavioral health, how are we going to ensure that all children are not missed through the cracks later on? So then our decision between behavioral health and child welfare was that every child was going to be reassessed every 6 months, just to ensure that we were meeting all the child's needs. And we talked about that. Hopefully this also falls with our assessment to the court regarding how the child is doing in placement. So then that is something that we agreed on. So some of the, if we go to the next page, some of the obstacles and barriers that we have identified through this process once we started implementing was getting the consent forms and the confidentiality, and then particular for the youth at 12 and older, that was something that is something that we're still working on. We had originally had a conversation with the privacy officer with behavioral health and our county council as to how we can develop a shared drive and what that would entail, and also getting information for children who are 12 and older, how we would be able to get that information if they're in need of treatment or not. So looking at the HIPAA, the state and the federal confidentiality laws that we're currently doing, looking at, and we have an additional meeting. And this came about I know that there's some counties who have already developed a tracking mechanism between behavioral health and child welfare, and again, to ensure that the child is being referred, is getting their treatment, or re-referred. And so that's something where we would like to be at, and that's something that we're looking at, working on right now. And when we met through these last year, our conversation was how to ensure that we, or backlog. And like I shared with all of you today, for us it was already an automatic process that we had, that we were referring children over to behavioral health when they came into care. So it was just identifying when the initial referral was done and then if there was a need for another. And so then, and here in the slide it says annually, but like I shared, we talked about every 6 months. And our process, which there is not, there's not a slide on that, but just to go a little bit more over the referral for the children 0 to 5, when an emergency response social worker is responsible to complete a referral to Healthy Beginnings. There's not a referral, like I said, to behavioral health. The Healthy Beginnings case manager then will complete the ages and stages questionnaire. The case manager will complete the referral to behavioral health if the children meet the above the cutoff. If it's below the cutoff, then the case manager may refer to behavioral health depending on other factors. The DSS liaison then would receive copies of the ASQs and inform whether the children are going to be referred or not referred, and also enter that information into a tracking system. They're responsible to give copies and information to the social worker, and like I said, in entering that information also on CWS CMS. Once the behavioral health then sees the child, then they are responsible to send a response to our identified KDA social worker, whether they meet the medical necessity or not, and entering that information into the CWS CMS notebook. If there are no behaviors that warrant a referral to behavioral health initially, children, the social worker will then complete a miss in a KDA referral and forward to behavioral health on a later date if that's what they need. So as to how we handled the referrals that are not promoted to a case, the social worker gives the parent or the legal guardian the information regarding behavioral health through an identification card, and inform the parent to contact behavioral health to set up an appointment. Child welfare social worker is responsible for completing the miss only and forwarding that to behavioral health. After submitting the referral, then the client would call behavioral health to schedule an appointment. And there was no need to consign consent, and behavioral health would be responsible for those. For referrals with the removal, we already talked about the referral for 0 to 5 to Healthy Beginnings. And for children older than 5, we complete the MIS form. The DSS KDA coordinator completes the cover sheet and signs the consent packets and sends it over to behavioral health. Through this process, we wanted to ensure that all those referrals were being sent and kept tracked. So then we even identified somebody, an office assistant, even within our department, to ensure that they were being tracking, and when they're being delivered, to even get we even get signatures that they have been received. And again, that's just to ensure that the referrals are being sent and received over at behavioral health. For our BFM, Court FM cases, fill out the MIS, the cover sheet, and submit the form again to the KDA coordinator for documentation. And for FR, permanency planning, adoption referrals, it's the same process. So going back to the slide, like every other county that I've heard with the high turnover, it's the ongoing training of our child welfare staff, and also moving resources around to ensure that we do have somebody always attentive to our ensuring that our referrals are being done, the myths are being done, and the referrals are being done sent over to behavioral health. And I believe that is something that is everywhere, but for us, we've continued, we're not meeting weekly since we already have our policies and procedures and our forms, but we're meeting at least once a month. And again, that is for us also to ensure that there's nothing that is falling through the cracks, or if there's anything that we need to change. One of our successes that Madera County had been working on for years was the RAP services. We did not have RAP services in place until this last year, and so then working collaboratively with EMQ and behavioral health and getting those contracts and identifying the children to be referred over to for RAP services. So we move on to the next page. Okay, so then we're moving on to the next slide, and Keith is going to walk us through some of these forms and our successes.
Good afternoon. This is Keith Crawford with Madera County. The successes we've gained through this is being able to provide the consent forms attached to the referrals. That's been a real good collaboration between the teams. And then identifying the ICC, the intensive case coordinator, which is myself, and the KDA coordinator through DSS facilitator. And we've been really blessed with having a good team on the DSS side, being able to coordinate this. It's like herding cats sometimes, so it's developed into a cohesive team, so it's been a good thing. We've had that open communication between the two coordinators. I'll go over there, she'll come over here if we have questions on calendars and whatnot. And of course, BHS and DSS have their own tracking methods, and then we've shared that communication, and that's been a real positive piece to the coordination.
Hello, my name is Art Galindo with Madera County Behavioral Health. And just to focus, some of our next steps will be to continue on with that discussion with regards to confidentiality that Patricia had referred to earlier. With the Senate Bill 543, the minor consent laws, that is the issue with regards to those children who are 12 years and older and legally can consent for their own treatment. So we will continue to have that dialogue along that area, as well as with the issues regarding a shared drive where we could, again, share information in one central drive. And this is in hopes of even streamlining and improving our efficiency of tracking all those referrals and services that are being provided to the children. I know that at present that the Department of Social Services is in the process of identifying a KDA coordinator. They have had others before, and they have been very cooperative in collaborating in a lot of very intricate pieces of information, so to ensure that these children get access to services and that there's responses to those services being offered. As stated before, that the dialogue is continuing with our management as well as with legal counsel, just to, again, to ensure that as agencies, as for behavioral health, that we are in compliance with all confidentiality laws with regards to the children. If we could move on to the next slide, I can go over, or Keith and I will review some of the forms that we are currently utilizing within our child and family team meetings, as well as those response forms that we are providing to our partners over at TSS. I'm going to turn it over to Keith, and he can describe a little bit more of the CFT form here.
When we first received some of the samples for the CFT, the Client Family Team Form, for the meetings, they were a little laborious. I do believe 5, 6, 7 pages long. So I appreciate the latitude I was given to bring this down to really just this one page and the sign-in page. And through the help of SLO, San Luis, I appreciate their team really coordinating with us on this. So it's just exactly what you see. It's easier to maneuver in a team meeting. It doesn't overburden the families or even the client who wants to give input. And on the second page, you'll see next just the sign-in sheet with a confidentiality statement on there, so everyone's understood that what comes up in this meeting stays in this meeting amongst the team. So, and then we date it, of course, and move on from there. And I appreciate the management team helping us out with this page too. But like I said before, this form was entirely too long, and I do believe we've come up with a successful form at this point.
It is important to note, too, that just as it states, a child and family team meeting, I think that both BHS and DSS have worked really well in focusing on the family and helping them and empowering them to understand this is their meeting so that they are able to discuss with us what services are necessary so that they can be successful in their lives, and also as a way to hold those treatment providers accountable for follow-through at various levels. So again, to support them in their efforts and participation in treatment. If we can move over to the next slide, I can discuss a little bit about the missed response form. And the missed response form again, and that missed is for the mental health screening tool. And this is the response form that is completed. It is utilized, first of all, to identify whether or not the child attended the scheduled assessment. And if they did, it also identifies whether or not they met medical necessity and if they met the KDA subclass criteria or KDA subclass criteria. Now, this is a modification of a form that was already in existence with regards to earlier, me had mentioned that utilizing the mental health screening tool as a part of our previous program or our already ongoing program. So it has been modified to identify those major areas so that once completed, this is sent over directly to the Department of Social Service KDA coordinator, so they then can log it onto their tracking mechanism and then refer it on to the assigned social worker. If we could move on to our next page there, our next slide. This slide here, this is the KDA referral form that is attached to the mental health screening tool, and these are completed by the Department of Social Services social worker at the time of referral. Now, also attached to these forms are the, as Keith had mentioned earlier, are the releases of information forms, again referring to confidentiality. And when a child is been placed into dependent foster care, and if they are under the age of 12, then it's the Department of Social Services who becomes the holder of privilege, so that will allows for them to consent for treatment and for the exchange of information, so that again we are able to share with them, the outcome of the scheduled assessment. In this form here, it has the basic demographic information. It also will identify the program component in which the child is involved in. Also on here, we do have something where it would indicate whether or not the child's bio parents are allowed to participate in treatment. This helps us as behavioral health understand how we're going to be involved in that treatment process, or also for follow-up if they are or not able to participate. Also in this form, there is the subclass eligibility criteria that's listed towards the lower portion of the form. This is information that's also evaluated or assessed for in order to determine whether or not, after they've met medical necessity, if they further meet the criteria for the subclass, KDA subclass. This form is completed and it's signed and is entered into the child's chart. Then it also is attached to the response form and then sent over to the DSS KDA coordinator. We could move on to the next slide, which it may show. this part right here is where we would indicate whether or not they met medical necessity, met KDA class criteria, and or subclass criteria. It also will indicate, what program that the child has been referred to if they've met medical necessity. And again, this is further documentation as to the outcome of the child's participation in a mental health assessment. And I know that we had discussed earlier, if a child does not meet medical necessity, then that information is sent over to the Department of Social Services. And if the child within the next 6 months or 6 months is still independent foster care, then the social worker would be, again, utilizing the mental health screening tool, and in going over that screening tool, identify if there are needs for a mental health assessment. If not, that screening tool would suffice as a means of determining whether or not they were needing that referral. Again, if there are indications that they are in need of, then the process in which they're sending over the KDA referral, that completed mental health screening tool and releases, just to update the information, would be sent over to behavioral health, where we would schedule them for an assessment. That, for the most part, completes our portion of the presentation and review of the forms here. On the slide, there is our contact information for both Department of Social Services, Patricia Calvillo and me, Wang, and then for ourselves at Behavioral Health, myself, Art Galindo, and Keith Crawford.
Great. Thank you so much, Patricia, me, Art, and Keith, for a really informative presentation about Madera County's work. We really appreciate hearing about that. And also, both counties, we really appreciate you sharing the specific forms and materials you're using, because I know that's something that's always helpful to counties. So at this point, we're going to be opening it up to questions. So if you'd like to ask a question, just go ahead and type it into the box on your screen, and we will Kelly will read the question aloud, and then we'll have one of our presenters respond. So Kelly, go ahead.
Okay, well, we have one question right now regarding TFCBT certification, and the question is that in order to receive the certification, you only have to do training and then the phone conferences. And then the second part of that question is, are there any links or information for training?
So I would say that was a question from Mariposa, I believe. I think you talked about TFCBT.
Yeah, I can send out the link for that. I'm sorry, I missed that. It is a 1-year training, and I think the question was, yeah, it is by phone conference. You do have to go to the initial 1-week training, and then after the 12 months, you receive the certification. I think at the 6-month point, right around there, they do kind of a booster training. So they do ask you to attend a 1-day training to then reconnect you back with the facilitator and all the resources that are provided through that training.
Okay, thank you for that. So we're still taking questions. If you have a question, you go ahead and type it into the question box, the chat box on your screen. We still have more questions we can come in.
Okay, here's a question from Madera County. Do you only have one ICC coordinator for the whole caseload? How does that person work in collaboration with mental health providers for that child or for the child?
Yes, that would be me on the BHS side of things. And basically, once the client's been identified, Art actually meets with them, the primary and the caseworker on the case, and then we set a time where we can meet to discuss the case, and then also have what I call a warm handshake to the family and the client to introduce who I am, what my role is, and then from there we set out the parameters of the meeting, the timing, and all that good stuff. So that would be correct. That would be my position.
Great, thank you for that.
Okay, so this is for either county. Can you speak to how your forms are completed and shared? Is this done electronically or by sharing paper? And if electronically, can you talk a little bit about how and what system you're using?
So why don't we start with Mariposa on that?
Sorry, what was the question?
How are you using your forms? How are they completed and shared? Is it electronically or by paper? And if it is electronic?
Yes, presently it is by paper. We utilize the scoring tool, handwritten tool, attach the scoring sheet, and now thank you for sort of instilling in our brain some changes we'd like to make for Madera's presentation on attaching consent forms to releases as well to our referral form to behavioral health for assessment of appropriate services. So yes, right now it's not electronic.
But then what we do after we receive a referral of behavioral health, we do notify child welfare via email, secure email. We received your referral and the client has been seen. So we send a confirmation that the client's been seen and assessed and that they either are in treatment or are not, depending on if the client refuses.
And we also do receive hard copy monthly or bi-monthly reports from behavioral health on the progress of the client, attendance in therapy, participation in therapy, and the sort of a more subjective assessment of what's happening with the client.
Okay, and Madera?
For Madera, this is me, Wang. And we have all of our forms, they're all on our, not our shared drive, but online. We have a web page that staff can access those forms online. So the MIST is something that we have in the CWS CMS system already. It's already in there, so staff can fill it out. And our packet really just consists of the MIST. Majority of the time it consists of the MIST. And then the KDA referral is also located online. Staff can certainly type it out online and then they can attach it to the MIST. And then we also have behavioral health who gave us electronic copies of their consent forms. So when we send the packet, what happens is staff will get these three things together, completed. Once it's complete, they'll send it to me. They'll give me the original signature package, and then I will go ahead and send it over to ART. And we have a routine run every day at before 2 o'clock. The packets get sent over to behavioral health. ART will review it, and then ART will send back a form. I think he showed one of the forms in the slide, and that form tells me that the child's been assessed, if they met medical necessity, or if not, that form tells me everything. And then we keep a log and track all of that at Madera, and I think ART tracks that as well. So we do have forms electronically, however, due to the fact that they need the original consent forms and original signatures, when we send it over to behavioral health, we send them the original.
Okay, next question. Are foster care, public health care nurses involved in KDA screening and assessments in your counties? We'll start with Mariposa.
For Mariposa, we do have a public health nurse here 2 days a week in child welfare services. She's not really involved with KDA referrals. She's pretty much following up, entering information into the HEP, health and education monitor, and also working with social workers on facilitating services for medical and dental services for children. So no, she's not really involved with KDA. She's only here 2 days a week as it is.
So for Madera County, sorry, I'm jumping to it. Anything else from Mariposa?
That's pretty much it. We're lucky to have her 2 days, actually.
For Madera County, we do have, this year we were really fortunate. We did get, we were able to have 2 nurses on our team. However, ours is a little bit different. Earlier, Patricia talked about the 0 to 5 population. And what we do there is when we send that population over to the Healthy Beginnings program, those cases get assigned. Now, the individuals or the agencies that participate in the Healthy Beginning program consist of public health, our early start education people, and our I want to say, I think it's mental health in our department. And so what ends up happening is when we send a referral over to HB, that gets assigned, and sometimes it just depends. Public health nurse, they then can go ahead and screen for that if that child needs meets KDA or not, or needs a mental health referral. So I can't say that, so in that aspect, the public health nurse can be involved in that process, but it's really, whoever that case gets assigned to, that will do that piece, that initial piece of it. In terms of our public health nurse in our office, they don't have any direct contact with those particular cases. In the past, what they've done is they've documented for us. However, since we implemented KDA in our department, it's been my job and whoever is going to take over the KDA coordinator, our department, to document in CWS that the referral was sent and what kind of services they are receiving. I don't know if you guys are aware, but you need to track that in CWS. And so, now that we have KDA, I've been doing that process.
Great, thank you.
And that's it for questions.
So we have time, if there's any more questions, that was the last one we have submitted, but if anybody has another question they want to submit, you can go ahead and submit that now. We'll wait just a moment here. Okay, well, it looks like we don't have any more questions. So I want to thank all of you for your questions, and once again thank our presenters, Susan and Chrissy from Mariposa, and Patricia, Art, me, and Keith from Madera County for their really incredibly informative presentations. We're at the end of our time, and we want to thank for all of you in the audience for attending. And once again, we encourage you to take a few minutes to share your feedback as you exit this session. With that, we'll conclude our broadcast. Thank you so much for joining us. Goodbye.
Bye.